Thank you, Danny, and thank you also for, especially for Dr. Roa, whom we were able to invite, even with this busy schedule. And also, it's an honor to be side by side with a legend. Okay, my topic will focus on diagnostic testing, updates, particularly with your RT-PCR, antigen antibody, and we'll touch a bit on the role of antimicrobials in COVID-19. So this is the current Philippine situationer as of September 9, 2020. And you see the confirmed cases by date of onset of illness, and it's really a dramatic decrease now in the number of cases, okay? And this is what they call this the start of the flattening of the curve, okay? And we want this curve to be downtrend, okay? And what we are experiencing now, hopefully this will really continue also next few weeks to tell that our cases has been controlled. And look at the reproductive number, which is an indication, a number that we always use, that a particular individual capacity to infect another individual is also an indication that there's an ongoing community transmission. It has been, for the past 1 week, it has been less than 1. In fact, in August 25, it's 0.89 plus minus 0.02, and then 0.86 plus minus 0.03. Okay, so this will always vary in terms of how many cases will be reported in a day. But to look at the countries in Southeast Asia reporting COVID cases, we are now number 1 with total cumulative cases of confirmed COVID-19, 241,000. So out of this 241,000, 185 of this has already recovered. And if you look at our death, number of deaths is only like 3,916. So more or less the case fatality rate overall, looking at 241, is really less than 1%. Okay, and this is the breakdown of the active cases, meaning these are still cases either in the hospital or in the treatment or quarantine facilities. Majority are still in the mild. Then you also have here 1.3% severe and 1.9% critical. I think this is the one that we are currently monitoring, because for the past 5 to 6 days or 1 week, our severe to critical has somewhat increased from a previous of 2%. It has now gone up like 3.1%. And if you look at cases like 685 and 990, possibility of higher risk for mortality, then we might add them also higher risk that they will be in the risk of death. Okay.
Ma, tingin ko dapat mag-apply na ako ngayon.
This is always what we monitor.
Pababa na eh.
To test, okay? As of September 8, the samples that has been tested is 32,000, and I think this is the target of the Department of Health, that at least in a day will be testing around 30,000 plus. And of course, when you test a lot of this individual high-risk exposure or direct exposure, then you would always expect that the positivity rate will also be very high. So majority of those positive are in the National Capital Region and in the Calabar zone. Now we go to testing. Why testing is very important? Because diagnostic tests for SARS-CoV is still evolving. And understanding the procedure, the nature of the test will be very important when we do interpretation of these patients, and the impact, okay, not only for us clinicians, but also for public health response is quite very important, okay? One, we need a test to find cases, and these cases are the basis why we do contact tracing. And this is also the basis why we said it will indicate if there is a sustained community transmission. And it's very important also that once you are positive, then you have to be isolated. And those who are in contact with that positive individual will be the one who will also be quarantined, both either mild or asymptomatic. The current IATF recommendation now is they should not be quarantined at home, but they should be quarantined in special treatment or quarantine facilities in order to really assure that there is what we call physical distance and prevention of or compliance of health protocol. But more importantly, testing in terms of those patients who are really symptomatic, highly vulnerable, treatment is important for them so that early management will also be in terms of putting this patient at higher risk for survival. And we have seen a lot of these patients already that when they go to the hospital early on, early clinical management, even if they will go into severe or moderate or critical um, um, clinical situation, most of them will always respond to early management and treatment. So this somehow is the importance of the diagnostic tests. So what are the available diagnostic tests that we have now? Okay, let's just take it one by one, how the tests are being done. Okay, so there are two types of tests that we are doing now. One is direct virus detection, meaning specific part of the virus, like with your RT-PCR, is either the envelope or the spike protein will be detected. And then you also have the antigen, no? In which you will also detect the nucleocapsid protein or antigen against the spike protein. And more or less, these two types of tests has the same principle, detecting directly the presence of the virus. The other test is the serology, what we call the antibody test. Okay? And with serology, you have the IgM, and then you have the immune globulin G. So this is the response of an individual upon exposure to a COVID-19 virus, in which your immune system will respond by putting up or producing antibodies specific against that particular virus. And this is also indirectly diagnosing your patient as having COVID-19. So currently, RT-PCR is the recommended test for confirmation. It detects the viral RNA of the virus, okay? And it can also be measured by the cycle threshold. Okay? So cycle threshold indirectly, this is what we call the viral number of amounts of the virus in that particular specimen that was detected. So I'll explain to you later on how this cycle threshold will be an important information for us, especially in terms of looking at infectiousness of a particular individual having a threshold value. And most of the RT-PCR test is also time dependent in terms of sensitivity of when to detect positivity, and we should be knowledgeable on when to maximize using this test. No? And I'll show you some of these slides. Okay, so currently this is the purpose of the test, as I've mentioned, confirming the cases, at the same time deciding on releasing of a confirmed COVID-19 patients from quarantine. I think what we're doing now is that we don't rely on RT-PCR now. It's more on symptom-based after 14 or 20 days from the hospital. It is the current protocol will recommend that they can be discharged, or they can be returned back to their home once that window period of observation will be achieved. Okay, they can also be used screening asymptomatic individuals, especially in those contacts with confirmed 19 patients. Although there is still some what we call unclear importance of diagnosis in asymptomatic individual, but at least this is the test that we are currently recommending, because there are those patients who may be asymptomatic, but they still harbor the virus and can be detected through your RT-PCR. And of course, if you have a patient coming in because of respiratory symptoms, it's really important during a pandemic that you need to rule out the presence of your COVID-19 by also testing them before they will be admitted into a non-COVID unit. Okay, so this is the interim guideline of the expanded testing, the use of RT-PCR by the Department of Health. And this is primarily driven by the fact that during the time, the number of testing laboratory was still very low. So we call this priority at risk population. So those patients who manifest with severe critical symptoms, those with comorbidities, even with mild symptoms, and those with mild symptoms, as long as they are healthcare workers or patients with direct contact or risk of exposure, and all asymptomatic, even if they don't have the symptoms, but as long as they have history of travel or contact or exposure, then they have to be tested. Now, the letter D, the subgroup D, has been also expanded, okay? And this will now include the contact traced individuals. So all individuals that are in direct exposure to those who are positive, whether at home or in the hospital, okay, or any setup, should be tested for COVID-19. And then healthcare workers are now segregated or stratified into the risk of exposure, okay? This will now mention the how frequent, okay, you will test this, especially for those healthcare workers with what we call high COVID exposure. So these are healthcare workers assigned in health COVID-19 units, okay, especially in areas like what they call the special concern areas. NCR is a special concern area. So this is a recommendation that all of these healthcare workers who are working in a COVID unit will also be tested at least once a week. No? And this is determined only also by the Infection Prevention and Control Committee of the facility. So this will always be under an arrangement if the ICC of that hospital will approve this particular protocol. And then the other group are high COVID exposure who live and work outside the special concern areas, may be tested up to once every 2 weeks. And then the other group is all healthcare workers who do not have high COVID exposure, but who live and work in special concern areas like NCR. They can be tested optional at least every 2 to 4 weeks. So I think the guideline is very clear on the frequency of testing, especially for the healthcare workers, which are the important population, because we are being the frontliners, we are always at a higher risk of getting the infection, and we don't want our healthcare facility that healthcare workers will also be positive, and that will affect the functionality of that particular healthcare facility. So this is just the definition of high COVID exposure. So directly working or indirectly involved in COVID-19 care. You have nurses, doctors, any staff working in COVID-19 facilities, hospital wards, emergency rooms, isolation facilities, quarantine facilities, including laboratory technicians and pathologists. Okay. And then we also have the subgroup E, and these are also frontliners involved indirectly in healthcare provisions. No? So these are at the level of the barangay, those distributing the amelioration, relief assistance, those in the prison Bureau of Corrections or Bureau of Jail Penology, including those who are in the swabbing centers. No? So they also are qualified to have to be tested with your RT-PCR. And then the other group, the other priorities, the vulnerable patients, especially those with comorbidities, okay? Those undergoing high-risk elective surgical procedures, so meaning those who will undergo aerosol-generating procedures, persons deprived of liberty, or institutionalized persons. So they itemize here this population. You have here pregnant patients, dialysis patients, immunocompromised, including that of HIV and AIDS, and those who will undergo chemotherapy or radiotherapy, again, under the discretion again of the clinician if this group of individual warrant testing. Okay. Now, this is what I was alluding to in terms of the possibility that your RT-PCR might have a false negative. Okay, so this is why that when you get an RT-PCR in your patients, you always have to look into what is the probability of that patient having a false negative or having a true positive. And here, they were able to track in terms of tally the days, okay, from onset of exposure. So this is 0, this is 7 days, this is 14 days. And they found out in the study that getting the sample at least 1 to 3 days after symptom onset, no? This is the highest, highest period by which the false negative is really very low. So meaning chances are, if the patient is positive, this is really true positive, and rarely this is false negative. Okay, so clinicians should consider waiting at least 1 to 3 days after symptom onset to minimize the probability of a false negative result. Okay, so the cycle threshold value has now been one of those indicators of infectivity. Okay, and the principle here is the lower the cycle threshold, then the higher is the viral load or the amount of the virus in that particular specimen. So that means also higher risk of transmission, highly infectious. And a cutoff value for one to be reported as positive in the PCR is more or less 40 and below. Okay, so if you are RT-PCR positive and then you are symptomatic, chances are your cycle threshold will be either 40 and below, and you don't know what viral load are you in, then it's better to really get the cycle threshold. And the positivity of your RT-PCR starts to decline by week 3 until it becomes undetectable. Okay, so I have here as a graphic presentation of the cycle threshold here in your x-axis and then your y-axis symptoms to test. Okay, so if you look at the red one here is the probability of positive from day 0 to day 3 of symptom appearance. You'll notice that the cycle threshold is usually very high, no? And at the same time low. So the lowest cycle threshold during this time is during the 5th day from the onset of symptom. Okay, so meaning from this time of the time that you get the test, then probability here that your patient is highly infectious because your cycle threshold is between 24 and below. Okay, so up to this day, and then and with the symptoms are already past this area, you'll notice that the cycle threshold is really very high already. Okay, so they put it in a way that when they did the culture, okay, the culture positive was not seen among those with high cycle threshold, and usually it is 8 days after. Okay, so no growth in the viral culture samples with the cycle threshold of more than 24, or from the symptom to test days more than 8 days. Okay, so they said that infectivity was only observed for RT-PCR whose cycle threshold is less than 24 and whose symptom to test onset is all less than 8 days. Okay, meaning infectivity of patients with cycle threshold of more than 24 and symptom duration of more than 8 days may be low. Okay, and this is also seen in this particular illustration. This is the culture positive and culture negative, and you'll notice that most of those who are culture positive are related with a very low cycle threshold, and those culture negative starts from 20 and above. Okay, so 40 more or less you have a culture negative. And for those patients who still have symptom from early symptom onset, less than 5 days, okay, you'll have a very high cycle threshold. Okay, so here you'll notice that higher infectivity during the early part of the course of the infection and lower infectivity if it is already more than 7 days from the onset of the symptoms. Okay, so another study here that was able to elucidate the importance of looking at the viral RNA by looking at also the CT value. Okay, so this is the positive culture. You'll notice that it's going down, and this is the result here is that the CT value equal or above 34 do not excrete infectious viral particles. Okay, so meaning if your cycle threshold is more than 34, more or less even RT-PCR, but the cycle threshold is more than 34, then that means your viral load is really not anymore infectious. So they somehow made this nice illustration of days from onset of symptom. Okay, so this is day 3 before the symptom, and then day 0, and then you have here day 5, day 10, day 15, and then day 20. Okay, so with day 0 to day 5, majority of secondary infections occur prior to this point. So what they mean by secondary infections? Those in contact with a positive individual, because the peak of your viral load and infectivity is usually between before the 3 days and up to 3 days after the onset of symptoms. Okay, so this means this is a very important part of the history, because if you have a patient coming in on the 7th day of illness, then chances are higher risk of infectivity the 7 days before that, before the patient came to the hospital. But if the patient already on day 15 or day 20 and still manifests with pneumonia, even if they have the pneumonia, it doesn't mean that the viral load is very high. Okay, so like for example, if the onset of illness is already between day 15 and day 20, okay, they can still have a critical phase of the infection, but it doesn't mean that their viral load is still is high. Okay, so the probability of culturing virus in severe critical illness or immunocompromised patient beyond this point is only less than 5%. Okay, so always remember that. That is day 15. But for those mild to moderate illness, then virus is unable to be cultured at day 10. Okay, so that day 10 and day 15. And longest duration of infectious shedding by culture reported to date is day 20. So ibig sabihin, meron pang nakukulture dito even at day 20. And notice that persistent or recurrent positive PCR possible up to this point or beyond. So meaning even with a high CT value, that it means the patient is already non-contagious. Okay, so this is the reason why in our new criteria for discharge or recovery, we don't anymore repeat the RT-PCR. No? So it's based on symptom. So that any patients presenting with mild to moderate illness, as long as the patient is able to complete 14 days in the hospital and or improvement in symptoms, then that means the patient has recovered. For those who are severely immunocompromised or critical, day 15, day 20 is the cutoff. Okay, so just to make sure that we don't miss anything after or the day 20. Now we go to the other tests, no? Aside from the RT-PCR. We have two tests, the antibody test and the antigen test, okay? And this is just to show you, when you do the test, you need to know, why are you testing, okay? At what point in time, what is the probability of that particular individual whom you test will have a positive probability, higher probability that it will be positive, okay? So pre-test probability is usually determined by one, the prevalence of infection in a particular community, or the presence of symptoms compatible with COVID. So meaning, if the patient is asymptomatic and is not in a situation in a community where there is ongoing local transmission, and if that particular patient will be positive with your antibody test, chances are that particular patient has a false positive, okay? And if the patient is negative, in which the pretest probability is very low, then chances are that if the test is negative, then that is considered as true negative. But if your patient is in a community with ongoing community transmission, and at the same time probably has a direct exposure to a non-COVID patient, or worse, patient is symptomatic, then the pretest probability will now be high. So that if you test that patient, chances are, if the patient will be positive, that's a true positive. And if that patient is negative, then that's false negative, okay? So this is the variation over time in terms of when to really get the test, including that of your RT-PCR, which I already explained a while ago. And your antibody test usually peaks at week 3, okay? So there may be some antibody tests that are so sensitive that it can be detected at week 2, okay? But most of the time, to maximize the use of this antibody test, you should get it after the 2nd week, here in this particular diagram. So the PSMID, the rapid point of care lateral flow antibody tests are not recommended, as a standalone test, for the diagnosis of COVID-19. And particularly using this for mass testing and clearance for work, okay? And if you want to use an antibody test, the preference here is using the CLIA method or the ELISA method, okay? And I think this is a statement of the PSMID that it should be done on the 3rd week onwards from the onset of symptom, okay? So remember, your antibody test will always be dependent on how sensitive the test and how specific it is. No? Sensitivity will determine false negative, and specificity false positive, because it can also have cross reaction with other coronaviruses. Okay? So again, just this test will also be its positivity predictive value will always be determined by the COVID prevalence in a particular community. Okay, so if the COVID prevalence is only like less than 10%, okay, chances are that the positive predictive value is really very low. Okay, and that's what's make it important that you need to get a kit that is 90%, 96% sensitive and 99% specific. Okay, so this is a meta-analysis looking at accuracy of the 3 serological tests, no? Because we don't have a validated serological test, no, using the antibody locally. Okay, so as mentioned, we have 3 methods: your ELISA, your lateral flow immunoassay. This is the one that most of us are using. This is so cheap. And your chemiluminescent immunoassay. Okay? So if you look at here, they were able to look at it in this way. If the prevalence is under 10% in a particular community, and if your patient is diagnosed with COVID, now this is true confirmed COVID, if you use your ELISA, you still have a false negative of 16%. Okay, so you miss 16% of that individual, which should supposed to be positive because this patient is COVID-19. If you use your LFIA, look at the false negative, it's 34%. It's very high. And you would really miss a lot of this in terms of detecting positivity of your patients. The CLIA, 98%, you only have 2% false positive, false negative. So that's why if you have an antibody test, we prefer that it should be this one or the ELISA. And then if a patient doesn't have COVID, what is the false positive rate? So meaning, it has its ability to cross-react with other coronavirus. Okay, so more or less, it has a very high specificity, only around 2 to 3% false positive. So currently, the Department of Health recommendation of the rapid use or the use of rapid antibody tests is it should not be used for diagnosis, for screening, return to work decisions, and travel entry decision. Okay, but I would like to share with you here the recommendation of the IDSA. Okay, and they said that the first recommendation is that you do not use your serologic test to diagnose a case of SARS-CoV-2 infection during the first 2 weeks. And just like what we had in the previous slides, they did a review of the different antibody tests, and they found out that the pool sensitivity at week 1 is only like 0.3 to 0.63, and on week 2 is 0.68 and 0.96. No? So as high as 0.96, but here you have also 0.68. So you really miss a lot of these patients if you will use the antibody test. So it lacks adequate sensitivity to rule out infection during the first 2 weeks of symptoms. And the second recommendation is that if a SARS-CoV-2 requires laboratory confirmation for clinical or epidemiological purposes, then they recommend testing using IgG or total antibody 3 to 4 weeks after symptom onset to detect evidence of SARS-CoV-2 infection. So this means you have to time it in terms of what is the maximum time that this test will be really positive. And if this is positive, if the patient is positive, then chances are that you have an exposure or the patient has COVID infection. And then for those patients, especially negative RT-PCR, but you have a high clinical suspicion that the patient's symptom is related with COVID-19, then this is an alternative way of diagnosing a patient with COVID-19 by using your IgG antibody. Okay, so assessing SARS-CoV antibody provides evidence of COVID-19, especially in these patients in which the clinical suspicion is very high. There is exposure, there is positive radiographic characteristic in your chest CT, and then even if the NAAT is negative or the RT-PCR negative, you can use your antibody using your IgG as the test to diagnose and confirm the presence of COVID-19. Okay, so this is just a summary of the table, how to interpret your antibody test. Okay, so this article somehow summarized when is this COVID-19, when is this antibody very useful. Okay, so serology testing is recommended. Rapid triage of symptomatic individuals in community settings where there is no access to your RT-PCR. So as long as there's no access, you can use this. No? So that's the reason why during the first early part of the month when access to RT-PCR was very difficult, you notice that antibody was the one, antibody test was the one recommended for diagnosis. And then testing all contacts of people with confirmed COVID-19, especially those who had exposure, and to document the presence of exposure and including surveillance. How many of those in the community are positive? There was, again, just to identify hotspots and populations that are particularly at risk. And it is not recommended, just like what the DOH, the PSMID guideline, testing the general population, testing to allow healthcare workers to return to work, and that also will be applicable to other workers, okay, and testing to discharge patients from the hospital. So this is my takeaway points for antibody test. No? So when you do the antibody test, first you have to know what test are you using, what method. If you're using LIA, then that is with a very low sensitivity. So I would rather use either the ELISA or the chemiluminescent assay. Then when you do the test, you have to know why are you testing, okay? So yes, for serosurveillance, just want to know how many are exposed. And if you want to use this for diagnosis, as we mentioned, to minimize false negative result, do this 3 to 4 weeks after onset of symptoms, okay? Now, you can also use this among patients who are RT-PCR negative, but clinically positive. And if the IgG is positive, then that could be your other way of looking that your patient is also COVID-19, okay? You cannot use antibody tests to assess risk of infection, okay? Meaning if you have an IgG antibody positive, can I be protected with this antibody? No? Cannot, because based on current literature or evidence, that antibody doesn't always seem to correlate with protection, okay? And if you still have an IgG antibody, it doesn't also mean that you cannot be reinfected. So there's no protective immunity even if you have an antibody present in your test. Okay. So the third takeaway point is you have to know the prevalence of COVID-19 in the population you tested. So this is the predictive value if you will test these patients to minimize false negative and false positive. So you have to have a very high sensitive and high specific test. Now I go to rapid test, no, based on antigen production. Okay, so rapid antigen can potentially be used as an alternative to RT-PCR for the diagnosis of COVID-19 among symptomatic patients during the first week of illness. So just like your RT-PCR, it's also dependent on the number of the virus that is in that specimen. And just like your RT-PCR, you'll be using here a nasopharyngeal swab to detect the presence of your antigen. And negative results from an antigen test should also be confirmed with an RT-PCR prior to making treatment decisions to prevent undue transmission. So I'll show you later on when do you consider confirming a negative antigen test in what situation that you need to do an RT-PCR and which situation that an RT-PCR is not needed to confirm the presence of this infection. Okay, so again, always in this discretion of the clinician, correlated with clinical, the presence of manifestations, the presence of direct exposure, and epidemiologic parameters if that particular individual is in a community with high sustained transmission. Okay, so this is the PSMID rapid review. Because of its overall low sensitivity and high uncertainty of its accuracy, they recommend that this test will only be done in the absence of an RT-PCR or if it's not available. And for those patients with high pre-test probability, such as those suspected cases in the hospital. Okay, so high quality validation studies are needed. So in terms of differentiating RT-PCR from antigen tests, both of these detect active, ongoing, current infection. Okay, your RT-PCR will detect the viral RNA, while your antigen tests the antigen. Okay, both of these use the same specimen, nasal swab. Sensitivity is higher with your RT-PCR compared to your antigen test, but look at the specificity. More or less, the specificity is also high for this, no? Equally high. And then the cost here is very low, no, compared to your RT-PCR. And I think this is the one that we really is tempting to use because the cost is very low compared to your RT-PCR. Okay, in fact, there are those tests that can be. I have seen antigen tests as low as 500 to 600 pesos. Okay, and it will only take around 15 minutes to get the results. So it's quick and it's cheap, and then more or less the sensitivity is a bit lower compared to an RT-PCR, but you got this specificity is very high. Okay, so this is the CDC interim guidance for rapid antigen test. It is helpful if the person is tested in the early stage of the infection. So as what I have mentioned, during the first few days of onset of symptoms, clinically compatible with COVID, you can maximize the test, no? Wherein the viral load is also high. Okay, so antigen levels in some patients who have been symptomatic for more than 5 days may drop below the limit of detection of the test. So this is where the sensitivity will now be a problem compared to your RT-PCR. So the first two antigen tests that have received FDA, EUA, this is US FDA, demonstrate sensitivity of as high as 84% to as high as 97%, no? Compared to RT-PCR. So that's really a very good test. So meaning these are the sensitivity that we need to look at in our test, no? When we buy an antigen test. In fact, one brand of the antigen test, when they did a clinical study using a cutoff cycle threshold value of the PCR, which is 38, they found out that the antigen positivity rate is 80.2% when the PCR cycle threshold value is less than 38, okay? And 97% when the PCR CT value is less than 25. So meaning the positivity rate is still dependent on how much the virus is replicating in that particular individual, okay? So meaning within that 5 days upon onset of symptoms, or at least 2 to 3 days before the onset of symptom, you can maximize this particular test, no? The antigen test, okay? And interpreting these tests should be in the context of, one, what is the prevalence of infection or disease in the community? And then the device performance characteristics, so that's sensitivity and specificity. And of course, the presence of clinical signs and symptoms and history of exposure of that particular person whom you tested. So these are the areas that you need to consider, okay? Now, it's necessary to confirm a negative rapid antigen test result with an RT-PCR, with the pretest probabilities relatively high, especially if the patient is symptomatic or a non-exposure to a person confirmed to have COVID-19. So meaning, these are the situation in which if your antigen test is negative, then you have to do an RT-PCR to confirm the presence of COVID-19 in a symptomatic and highly compatible COVID-19 case. Now, if you want to confirm an antigen test result with an RT-PCR, you have to also observe the collection time, the time interval. Okay, so it should not be less than. Samples collection is less than 2 days, so it should not be more than 2 days separate, no? Because you want to maximize the timing that the patient still have a viral load count during the time when you do the antigen test. Okay, so confirmatory RT-PCR testing following a positive antigen test may not be necessary. Okay, so hindi mo na kailangan mag-confirm ka ng RT-PCR if the antigen test is positive. especially if the pretest probability is very high, the person is symptomatic, and the person has a known exposure. Okay? So these are very important information that you have to look at when you are testing a patient with an antigen test. And confirmatory, when the pretest probability is low, those persons who receive a positive antigen test then should be isolated, because until such time that the RT-PCR is there and it will tell you negative, and that's when you can release this patient from isolation. So in a way, confirmatory RT-PCR following a negative antigen test used for screening testing may not be necessary. Okay? So pag negative ang antigen test mo, you don't need to do confirmation. If the pretest probability is low, the person is asymptomatic or has no known exposure. Okay, so this is how I look at this now. So when do you use this antigen test? One is point-of-care diagnosis of COVID-19. For symptomatic individual, if the patient is symptomatic, best to test using your antigens first 5 days of symptoms. Your viral load is high enough to be detected. If positive, that will confirm the presence of infection, and then you do early clinical management, contact tracing of exposed individual. If negative and the patient is symptomatic and you do it with the first 5 days of symptoms, then you need to confirm it with RT-PCR. Because as I've mentioned, your RT-PCR has a higher sensitivity over that of your antigen test. So these are just a few times that you need to do an RT-PCR confirmation if your antigen test is negative. What if the patient is asymptomatic and that patient has a recent high-risk exposure of known COVID-19? Okay, so best to test this individual is within 5 to 8 days after exposure. Okay, just like your RT-PCR. Now, if positive, then that will tell you that your patient has the exposure was successful. Then you have to isolate. And remember, since this patient is asymptomatic, you have to quarantine them and then observe for the onset of symptoms or deterioration. Now, if the test is negative in an asymptomatic individual, but at the same time with high risk exposure, now it's the discretion of the clinician if you will proceed with an RT-PCR to confirm the presence of COVID-19. The CDC has also mentioned about screening in high-risk congregate settings, no? Because of its ability to quickly identify person, because it's a rapid test, where the risk of asymptomatic transmission is high. They also recommend use antigen tests, no? Such as prison, schools, factories, home for the aged. Okay, and this is just a new IATF resolution. They now said that antigen tests is a substitute for RT-PCR. So you meaning if there is no available RT-PCR, and then you can use this test, pre-boarding requirement for asymptomatic domestic tourists before departure and travel to tourism destination, or requirement upon entry at the place of destination in accordance with the protocol of the LGU. Okay, provided that the test should be taken within 3 to 5 days upon entry at the place of destination. The other approved resolution here is testing of domestic tourists who turn symptomatic, no, at the place of destination. And you can use this in symptomatic this population if without, okay, so if that particular destination doesn't have any RT-PCR capacity. Okay, so that is now one of the updates on resolution on when to use your antigen test. Okay, so I will now proceed with treatment, and I will just focus on the role of antimicrobials. No? So this is the W classification of the clinical management of COVID-19, and we know that we have patients with COVID-19. They also present with pneumonia. The chest X-ray will always be compatible with pneumonia. The most important question: should I cover them with antibiotic? In fact, they are already confirmed with COVID-19. The second question, if this is COVID-19, is antibiotic indicated? What is the risk or the rate that this patient have co-infection with a bacterial pathogen, either acquired in the community or acquired in the hospital? Okay, so in this current treatment recommendation by the WHO, pneumonia antibacterial treatment is indicated only for those COVID-19 suspect or even confirmed if they are or presenting with severe to critical clinical manifestations. Okay, and that was also the recommendation in this published article. This is by the European Society of Clinical Microbiology and Infectious Diseases, the ESHMID, okay, made the recommendation when to treat CAP in a pandemic or during the COVID-19 pandemic. Okay, so they said empirical coverage for bacterial pathogens is recommended, but is not required in all patients confirmed with COVID-19 related pneumonia. Okay, so these are the pathogens that they usually recommend that the antibacterial should cover for patients with moderate, severe to critical. It should cover for Streptococcus pneumoniae, Haemophilus, Chlamydia, including that of Staph aureus. Okay. Now, if you see that that patient also has some risk factor that before admission has been taking antibacterial agent prior to admission, then you need to test the sputum and blood cultures as part of the workup in order to document the presence of multi-drug resistant community-acquired bacterial pathogens. And part of the recommendation also is procalcitonin could be helpful in limiting the overuse of antibiotics in these patients. And another paper here in the same society, okay, more or less gave us some rules to follow in terms of COVID-19 antimicrobial stewardship, okay? So they said do not neglect stewardship even during this pandemic. Again, the principle of treating or giving antibiotic will only be reserved for those patients with severe presentation. And at the same time, it should be stopped as soon as possible if the probability that a superimposed bacterial infection is very low. And de-escalation if the patient wants or is able to tolerate oral antimicrobial, okay? And in fact, they also recommend here that duration should not exceed 5 days in most cases. And the recommendation based on their clinical guidelines in Europe, they always cover for Streptococcus pneumoniae and also including that of methicillin susceptible Staphylococcus aureus, okay? So what about those COVID-19 who developed ventilator-associated pneumonia, okay? So treatment should also be based on local resistance and adapted according to the microbiological result, if there's any, okay, in that particular setting. So if you are in a hospital where you have MDR Pseudomonas, MDR Klebsiella pneumonia as one of the most common cause of ventilator-associated pneumonia, then those COVID-19 patients developing HAP or VAP should also be covered with appropriate antimicrobial based on your antibiogram. Do not use antibiotic as prophylaxis to prevent bacterial pneumonia, okay? Now, if during COVID-19 treatment, a secondary respiratory worsening occurs, one should reconsider the use of antibiotics after taking adequate respiratory samples and performing radiological diagnostics, okay? So meaning, if during the course of the COVID treatment, and I think we have a lot of this in our cases in ManilaMed that on the 14th, 15th day, or even as early as 9th day, some of these patients also have what we call worsening of the clinical manifestation. No? Now, they said that you just have to be careful because there is also what we call worsening attributable to your hyperinflammatory phase, which can also occur during the 7th to 9th day after onset of illness, okay? Rather than to a bacterial superinfection. Okay, so this is something tricky because you need to rule out also if the hyperinflammation phase, the one causing the secondary worsening, or if it is secondary to your bacterial or secondary bacterial infection. But more often than not, since it's very difficult to rule out, we also give empiric broad spectrum antibiotic to cover for what we call possible hospital-acquired pneumonia with progression of your chest x-ray on the 7th to 9th day of hospitalization. But keep in mind that other factors can also be the cause of worsening of the symptoms, okay? You need to rule out myocarditis, you need to rule out pulmonary embolism, or even fluid overload should also be ruled out in that particular situation. So this is an article shared to me by Dr. Roa regarding a cohort study of empiric antibacterial therapy and community onset bacterial pneumonia in patients hospitalized with COVID. Okay, so during the early empiric antibacterial therapy, 56.6% of patients receive empiric treatment, and remaining 27% vary in terms of the hospital. Okay, and as time goes on, in terms of the longer that we have been dealing with the pandemic, they noticed that the empiric antibacterial treatment was decreased over time. Okay, so probably this is a realization that most of the community onset bacterial infection rate is not really that common. Okay, only 3.5% confirmed. That's why stewardship is needed in terms of when you do and start antimicrobial among your patients with COVID-19. Okay, although diagnostic is very limited, most of us cannot even isolate the microorganism. Okay, and it's difficult to just wait for this culture to come out and then give your antibiotic. But probably if you get a procalcitonin and your procalcitonin is less than 0.1, then look at the negative predictive value here is 98.3% to confirm the presence of an ongoing bacterial infection. So meaning less than that, then chances are your patient is not really co-infected with the bacterial pathogen. Okay, so these are the 32 hospitals in terms of coverage. How many covered for community-acquired antibiotics? How many covered for anti-MRSA and anti-pseudomonal and antibiotic? Okay, so it's really something that very highly variable, no? among different settings. This is hospitals in the United States. Okay, so out of the 1,705 patients with COVID-19, 56.6 were prescribed early empiric antibiotic. Okay, and 3.5% that are confirmed community onset. And I think we have now a realization that as low as 27% and as high as 84% among these hospitals really covered empiric treatment using your antibacterial, different antibacterial that will cover for common community-acquired infection. So here, these are the bacterial and fungal co-infections that were documented in this particular article. Okay, you can see here that really a higher number of organisms that are also multi-drug resistant can be isolated among your COVID-19. So meaning these are patients in which they also have previous history of antibiotic intake, and that's why when they are longer staying in the hospital, they stay in the hospital longer, higher risk of hospital-acquired infection, then chances also are they have multi-drug resistant organism. And most of the isolates here, in fact, there is what we call both are isolated in respiratory and blood. So you have here Pseudomonas, which is commonly isolated in respiratory. You have MRSA, isolated in the blood. And then you have here Klebsiella, E. coli. And in fact, you also have Candida in this particular report. Okay. So with treatment, I would just like to show here that the Philippines is one of those countries that are participating the WHO Solidarity Trial that is looking into several of these antiviral treatment. No? And currently, the regimen that we're using now, we discontinued hydroxychloroquine. It's not anymore part of the study protocol. The lopinavir was also scratched off in the protocol. So right now we are using either remdesivir or interferon. So this is the different government and private hospitals participating in the WHO Solidarity Trial. So it's either they will be randomized into local standard of care, that's the blue one, okay, or the use of remdesivir, the yellow one, and then the violet one is the use of your interferon. Okay, so I think that's all for my part, and I'll now give the floor to Dr. Camilo Roa. Sir.
Thank you, Jim. Let me just find my slides. It's always nice to share the presentation with Dr. Solante. You know, we actually were born in Cebu, same place, and maybe that's the reason why we have the same habits. So Dr. Jean tackled first two parts here, the diagnostic test and antimicrobial treatments. I will now go to the non-antimicrobial therapies and then present to you a concept called long COVID. This is something quite new. Okay, so as spelled out by Dr. Jean, this is really, this starts as a respiratory infection involving the lungs, and as the condition worsens, you have greater lung involvement, and even to the point of destroying lungs potentially, and then later cure in terms of fibrosis and so on. And the patient can really get very bad. They can actually die from it. Now, I'd just like to mention that this is not just happening in the lungs. The virus goes where there are ACE2 receptors, and therefore you can expect changes in the other organ systems that are easier seen in the lungs, but actually present also. And mentioned by Dr. Jean as well is that at the start you have more of the viremia that's taking place, and then you have the fever, the malaise, and so on. But what actually kills patients would be the onslaught of the so-called cytokine storm that happens around this part, worsening the lung damage. And as you can see, the viremia actually starts to fall around this time. That's why he mentioned that the RT-PCR can be negative later part in the course, but the patient can still be very sick. So what I'm going to take in this part now is what we do for the cytokine storm, and then the other things that we do after the so-called cytokine storm. Okay, where we now deal with the, trying to minimize the alveolar injury and trying to modulate the repair that happens in the lungs as well as in the other organs. Okay, so this is the concept of the cytokine storm, and essentially what stands out here is the need to modulate the inflammatory response. And therefore, it goes without saying, the first consideration would be the corticosteroid. But mind you, there's another cytokine that's also stood out through these months, the IL-6, and therefore I would also discuss on the anti-IL-6. So dexamethasone is the one that has been studied. It's a convenient corticosteroid because it can be given once a day. It's effective orally or IV. And that has been included in the large trial, the recovery trial in the UK, that recruited almost 12,000 people. And dexamethasone was one of the treatments that were randomized for patients to receive, including the other drugs that have already been debunked, like the anti-HIV, the anti-malarial, and even azithromycin. Okay, now let's look at dexamethasone. Okay, looking at the intended outcome, the all-cause mortality as the primary efficacy, and then secondary outcomes, duration of hospitalization or need for invasive ventilation, but mainly the primary efficacy parameter. And because the study was very large, there was enough there to study dexamethasone versus the usual care. So fairly good sampling size. And this is what was found. And I think most of us are aware of this because we celebrated when we found that dexamethasone actually prevents death in COVID, in severe COVID actually. And as you can see, the survival advantage of dexamethasone is shown here. This is mortality for usual care. This is mortality for dexamethasone. And that is represented here in this empty diamond here. That shows that dexamethasone is better in terms of mortality. But take note that when they look at the stratified the condition into severity, most of the advantage actually happens if the person is already on mechanical ventilation, meaning very sick already. So maybe the lungs are flooded with all these inflammatory products, cytokines, and then you have also protection, lesser than that, but patients still requiring oxygen. Meaning there's already pneumonia there. But take a look, when the steroid was used when the person is not yet requiring oxygen, maybe having some the viremia, the systemic manifestation, but not yet really in a storm. Okay, look, the graph now is towards the other side, meaning its standard of care may actually be a little better, although the 95% CI crossed midline. So what I'm saying is that dexamethasone is of proven value in terms of survival advantage, but not among those who are mild. And this is, as you can see, you have even more deaths here numerically. And this was born in earlier studies that included the SARS-1, the first SARS, where viral shedding actually worsened with early use of corticosteroid. Okay, but however, if you have already a patient requiring oxygen or actually very sick, with critical care level, then by all means we should give dexamethasone, and that has now been part of the international recommendation for COVID. Now, what applies to the statement of dexamethasone applies to the other corticosteroids in equipotent doses, like hydrocortisone, prednisone, and even methylprednisolone. Okay. Then let's go to the anti-IL-6, anti-IL-6 receptor, tocilizumab. You know, tocilizumab has been there for rheumatoid arthritis, but I never got to use it before. But when we started using it for COVID, it gives us really a very happy observation in terms of response. We were very happy because, as shown in this study, an early study in March, uncontrolled, that the CRP actually falls quickly, the temperature goes down quickly with tocilizumab, the oxygen requirement also goes down in these patients. And you know, I have friends we treated and they really improved. I mean, even the O2 saturation improved. So these are things that you can observe, and we thought really it's really a very good drug, and it goes with the mechanism of against cytokine storm. However, when the first of the several placebo-controlled trials came out, okay, and this one is the Covacta trial, last end of July, then it in the 450 patients, okay, there was no difference in mortality, the primary efficacy parameter. That's very unfortunate. So there was no difference in the death rate, all-cause mortality. However, you take a look, still you can make out some advantage in terms of earlier discharge or ready to discharge with tocilizumab compared to placebo. So I guess maybe 450 patients are not really enough. There are still studies coming out, and we look forward to the new developments as far as the anti-IL-6. So negative trial it is, it's worrisome, but let's hope that the other trials will come out better. Also, the recovery trial has been changed in a way, modified, such that there is another randomization after the initial treatments. Okay, if they are still hypoxemic or they are still high in the inflammatory parameters, then they can be randomized into TOSI versus no other drug. And then let's see how the outcome will be. It's still upcoming, and I hope that this really comes out positive. Okay. The other non-antibiotic treatment, non-directly microbial, although there may be some mechanisms towards that, is the use of convalescent plasma. And the experience came from the cases of Ebola and other serious illnesses with convalescent plasma. And in COVID, we actually documented in earlier studies that the CRP goes down, the lymphocytes recover, and the O2 saturation actually gets better. So it seems promising, okay? And there was a study a couple of months ago that showed actually that if given early, there's a survival advantage of convalescent plasma versus the non-transfused. Okay, and unfortunately, especially if the content of the plasma is quite high with the antibody titers. And unfortunately, another study came out that was also controlled that actually showed the other way, meaning there is no survival advantage. So as far as the evidence out there, it's still not clear how we should be able to make use of convalescent plasma. The US FDA authorized its emergency use, but that has been criticized by the American Thoracic Society just recently. Okay, since the experts say that there is still inadequate evidence in demonstrating a clear benefit to patients. But I'm hopeful too. But of course, we know that convalescent plasma is not a nucleus. It's not also inexpensive. But I have high hopes there that, you know, when you look at the blood picture in a patient with COVID, it's really disturbed. And it may not just be the antibodies and so on. There might be something in convalescent plasma that can restore the healthy balance. We just don't know it yet. So the bottom line is, as we have been doing here, we are allowed some compassionate use, but not yet really for prime time, and that we might consider it early than late. Then the other drug that's non-antibiotic is the anticoagulant, and this stems from the fact that in autopsy cases of COVID victims, there's a lot of thrombotic event documented in large vessels, in small vessels, even near the capillaries already. And we have seen that embolism has been associated with COVID. There might be other cofactors there, but when you have embolism or even markers of, when you have a clot formation like D-dimer, it's really, a measure of severity and meaning less survivorship. So it's worrisome. So the American College of Chest Physicians, like a couple of months ago, that's May or earlier, yes, came up with an expert panel report that actually recommends, or actually just reminds, because this is already a recommendation, that we may consider actually thromboprophylaxis in most of these patients, but some caution on the higher dose, full dosing, and you need probably additional guidelines if you want to use higher dosing. And we just completed our European Respiratory Society convention, and this slide came out there, where it says that those who come in as severe COVID already, requiring ICU management, maybe they have to be given therapeutic anticoagulation rather than prophylactic. Or those who are not that severe but will have inflammatory markers suggestive of, clotting, or likely clotting, then they are given also therapeutic anticoagulation. But if not present, the inflammatory markers or actual coagulability markers are not high, but there is risk factor for DVT and so on. So they probably should be given still, and they have COVID, prophylactic. But if they don't have any of these, maybe we should avoid prophylactic anticoagulation. Unfortunately, as I mentioned, we still lack the evidence. Okay. And there are some cautions that, we have seen among those with therapeutic anticoagulation cases where they develop actively bleeding and quite problematic bleeding, including that of in the CNS. Okay. Now, how about oxygenation and ventilatory support for this patient? What is the evidence? Of course, if there's a situation of hypoxemia, we have to relieve hypoxemia. Because basically, when you lack oxygen, you have lactic acidemia, and then you get into trouble. The enzymes will not work very well. But what should we use? What should we do? Should we put them on ventilators, especially if they come in profoundly hypoxemic? What guided us early on is this experience published from Wuhan, where they had a group of survivors and group of non-survivors. And what obviously is different from the two groups is the presence of this red part here, meaning invasive ventilation. So it seems early on that if one is intubated, the chance of not surviving is higher. Maybe it's a marker of severity, but we also know that intubation and mechanical ventilation carries with it side effects that can actually cause death. Okay, they can also be an entry of bacterial infection with resistant organisms. So later on, we realized that not all patients with severe COVID with bad hypoxemia actually need mechanical ventilation. In documented by studies like this is a dual energy CT. It's been shown that what happens in COVID is that uh, the normal hypoxic response, meaning this is the thing that shuts down circulation in pneumonic areas. You saw there were patchy pneumonias in the X-rays before. The natural response is for the circulation to be moved away, shunted to other areas that are functioning, so that oxygenation is maintained. What happens in COVID, and this we are really learning, this is different, is that instead of constriction, we have actually dilatation of this area, promoting shunting of blood, meaning blood goes through without getting oxygenated, creating hypoxemia. And these are in patients where the lungs are not yet that stiff, as the same situation when we see very bad oxygenation in ARDS. Here it's more of a VQ mismatch rather than the baby lung or the lungs that are quite stiff. And for the baby lung, we have to expand that lung so that we have use high pressures. We put the patient on the machine. But in the case where it's not yet the case, although this is a continuum, but early on, we probably should not put the patient on ventilator immediately. We should not intubate them immediately, but support oxygenation with specific devices like the so-called high-flow nasal, which is now shown to be very, very helpful and have actually prevented patients from getting intubated, because after a day or two, some people actually just reverse as far as being able probably to handle the virus with their own immunity. This is the picture of Dr. Li Wenliang, the one who did a whistleblow on the occurrence of COVID in China. Okay, unfortunately, he caught it from his patients in February 1. And this is the high flow nasal, which is applied to him. Okay, it's very easy for the patient to use. They're not intubated. And as I said, in many of the cases, intubation actually is prevented because somehow the immune system turn around. You just wait for it. Okay, unfortunately for this good Chinese doctor, he died a week later because the condition in the lung worsened and worsened, and he needed to be on a mechanical ventilator. Okay, so we have the evidence that this helps, but it's still not well written out. So it's still mainly anecdotes. But what is seen clearly is that with the high flow nasal, okay, we prevent intubation. Unfortunately, we don't have it yet as something that prevents overall mortality. So the case is still being written up, the case of COVID. But certainly we don't intubate quickly because they actually suffer from the intubation and from the machine. Okay, now there is the other facet now that we are using the ECMO, which is a very terribly expensive treatment, but has been shown in more recent trials to be actually being able to prevent death in majority of patients that these are being applied. It's early days in the country, not all centers have it, but it's encouraging that this is being studied. And maybe we should not be using this late in the course, but early, so that they can be weaned off from the machine early and preventing the side effects of a mechanical ventilation. Okay. Now, then I have to mention as part of my report here, the reiteration that there are identified risk factors that are associated with higher mortality risk. So that's part of the non-antibiotic care that we should have in these patients. Or in the first place, those with risk factors should actually do a lot more to prevent them from getting the disease and actually getting severe and getting a mortality situation with it. So, for example, we have AIDS. The higher the AIDS, the higher the death. So, since we cannot change age, those people who belong to the senior age group or the older, in fact, then they really should take care. I mean, they hide. They should not go to the supermarket and then they have to do all the things that prevent them from getting sick. And the other things that actually are associated with more serious COVID, and this is in the form of various comorbidities. So the thing to do here is actually to maintain the medications for these comorbidities. If they are indicated, the reduce exposure so that they do not observe, and again to also reduce exposure to actually getting COVID. So there's a lot we can do, and that's why probably we have less deaths now, because people learn to realize what can be done actively, proactively to prevent getting COVID, particularly if they have any of these risk factors. And finally, I'll give you the concept of long COVID. It's a new term, actually. And this stems from the fact that even after the acute phase, here is an acute phase in this diagram here, where we have a lot of symptoms. Okay, days, weeks, and even months later, they continue to have this. And this is something that probably is not just related to, severity, because this also happens among those where the condition is mild and they actually recovered even at home. And yet they persist to be having symptoms after they have been declared to be free from the COVID. So maybe in COVID, we should have it in mind as something not that acute, but something really much longer. Okay. And we thought that some of these symptoms that include fatigue, dyspnea, were probably coming from the lungs because of the situation of the lungs getting dense. GGO becomes crazy paving and consolidations. But in general, by and large, in all the studies on this, there is some resolution and continuing resolution even after discharge. So really what is being felt is not necessarily the effect of residual changes in, say, the lungs. Here is another study looking at CT scans and lung function tests after discharge. And all these, the fibrosis, the abnormalities actually gradually track down. And yet people still feel not so well. Okay, this is lung function test. And while there is some persistence in the reduction in oxygen efficiency, most of the lung function parameters are actually okay. Okay. Now, maybe it's not just the lungs, it's the heart, because the heart is also involved. Okay. And in fact, they have shown in this study, post-COVID, is that the cardiac MRI showed some effects of COVID in the heart. Big percentage, actually, 78%. And ongoing myocardial inflammation has been documented, even after they have been discharged or considered okay. And the authors here look at myocardial biopsies showing lymphocytic infiltration with myocardium, and the myocardium actually are thickened, meaning a little edematous. And this is already two months after COVID diagnosis. Okay, they look at functional MRI and they show the inflammation. Okay, and they have technical terms there: native P1, native P2, and so on. So there could be something in the heart, but it's not necessarily associated with the reduced AF, the ejection fraction, or I think the worry here is more of arrhythmia. But if they plot these are really persisting versus normal in those who recovered from home, meaning mild, didn't have bad hearts. Okay, of course, worse in those who were in the hospital for the heart as well. Okay, and so even the tropi. So there is something in the disease that actually lingers, not necessarily because they have been very bad, they have been very severe, but really the condition, even if not very severe, lingers. The same is true with neurological manifestation, neuropsychiatric manifestation. In fact, they were labeled as something like, this is just, being afraid, or mental health is affected. But really, there are some residual things in the brain, but there are those who actually fully recovered. And yet, they don't want to return to work because they are still symptomatic. Okay, they're symptomatic. And so what should we do? I guess the pictures I showed you represent organ systems where we have monitors, but I suppose the effect of the COVID can happen in the other organ systems where you have the ACE2 receptors. So what should we do? We should understand that this condition really is not a short-term illness. It can be in more than 2/3 of cases be followed with some symptoms that persist even if they are already home or supposed to be well. And that we just don't make them like encourage them. Okay, you ride a bicycle, you take run, and because you're already well. No, because they can actually still be having some difficulty doing all those. So we have to understand the COVID patient. We have to make sure that there is really no big residuals happening. And when we do that, we support them, and they need our support to be able to get through this phase, the long COVID phase, until such time when they actually fully recover. And that requires the doctors as well as the family to actually help this patient. So thank you very much for your attention. I will stop sharing now.
Thank you, Doc Roa and Doc Solante. So we now open the floor for some questions. Open forum if ever you want to have any clarifications to the discussion earlier. Please raise your hand if you have questions. Or if you do not want to raise your hand, you can also put it on our chat. Doc Solante, there was actually a question made earlier by Ma'am Lelet. She asks, how can you detect contamination of RT-PCR as a cause of positivity for COVID?
Yeah, that's a good question. But remember, your false positivity with RT-PCR is really very low because the specificity is like 99%. Okay? And if the clinical presentation may not be compatible with COVID, that's one. And I think there are reports that if the patient is asymptomatic and then the CT value or of exposure, chances are you get, if the patient is RT-PCR positive, then it's better to look at the CT value. If the CT value is between 37, 38, most likely that can be a false positive. But again, it's really difficult to say that that is false positive because it's not common for an RT-PCR to be false positive. Danny?
Yes, Doc.
I have a question to Dr. Roa. So, sir, you mentioned about the long COVID complications, and I think we already have a lot of these patients. 50 years old, 60 years old, even after a month, 2 months, they still complained of difficulty of breathing or shortness of breath, cannot do their usual function at home just by walking few meters. They had this easy fatigability. So does that mean that we need to do 2D echo? We have to work them up every month, or what is the frequency? What is the recommendation in terms of really tracking this type of long COVID complications and documenting this, the one that you mentioned about myocardial involvement, like pericarditis or something like that?
So thank you very much, Jean. Really, this is a new concept. Before we thought, pag magaling na sa COVID, okay na yan. And they actually are not most of the time. And we should, number one, understand that this is the situation. They're not malingering. They're not just afraid. They feel something. Okay. And then Number two probably is to make sure that indeed the other organs have already recovered or there is no residual abnormality that will require pharmacologic intervention. So if for the heart, they have to be seen by the cardiologist. For the pulmonary, we can make some assessment as well, or hematologic. We had a patient before with fairly haywire laboratory, so we just make sure that they are already going towards normality. And then lastly, if you don't have those, we just have to understand them and help them along the way and reassure them that the COVID effects, unless you had a hard one like a stroke or a myocardial infarct, they are generally reversible. So it reassures them to be so. You see, I also have this top cardiologist friend. He went to high flow nasal but never got intubated. But when he came out of it, he was really not getting well. I mean, he's a type A personality, but it took him months actually to come up to where he used to be in the apex of the specialty because of this long COVID thing. And I guess there will be more written about it in more current literature. The British Medical Journal actually sponsored a symposium on this.
Sir, follow-up question. Most of these patients, when they go out, okay, some of them really requires oxygen at home. And I noticed that in their chest X-ray, even if they are discharged, they still have this infiltrates. No? And in some of these, they're being read as pulmonary fibrosis. So would you think that, especially among some of these patients, do not have any history of smoking or any other risk factors that can increase risk for like bronchiectasis or emphysema? Is this really part of the clinical course of COVID that within a few weeks or within the clinical course, they always develop pulmonary fibrosis?
Yes. If you have lungs inflamed, the next thing that happens is fibrous tissue are being laid. Now, having said that, the concept should be that fibrous tissue laying down is not a terminal event. That fibrous tissue can still remodel and actually disappear. It may take a while. So the bigger the degree of lung involvement, like really a bad inflamed pneumonia lung, then the longer it probably will be able for them to shake off this thing. And since, even in the US, this is their policy, if you are already beyond the viremia and they have documented no more, they have gone beyond 40 days actually, the patient still requires oxygen. They are sent home with oxygenators and with the expectation that these patients actually get through it. May take weeks further of oxygen at home, but they actually improve with this. So we are not seeing the type of fibrosis that is progressive and worsening once it started. Fortunately, we are not seeing this with COVID.
Thank you, sir.
Thank you, sir. Actually, there are several questions in their chat. One of them is directed to Dr. Roa. How may a physician give clearance to a seaman to go back to work after having COVID-19? I guess the concern is that if you have come from long-standing disease and you're considering long COVID, how would you go about clearing a patient to go back to work?
So these are patients who are off the virus already. They have recovered, and the question is whether they are still having the long COVID thing. The long COVID is seen in about 2/3 of patients. 1/3 should be fine. So if by symptoms and by ordinary workup, they're okay. And of course, they will deny symptoms because they want to go to work. Okay. But you have something that they cannot deny, the pulse oximeter. Okay. So if they're already fine with that and they are mentally set to do that, they can go back. They can go back to work. They will tell you if they are ready or not, because the long COVID really is something that's if you can see Richard Quest narrating it on TV, you really know that they are that sick and probably not when they go to work or as a seaman, they probably would know that they'll be there alone and they would probably not risk it. So when they come to you and they say they're okay, and you make an initial test, they're okay, then fine, we can go.
A follow-up question as well, Doc. Do you recommend pulmonary rehab for patients who had severe COVID pneumonia?
Okay, so the long COVID is not chronic COVID. This is the other thing that they were stating, that there is natural recovery. So, and the recovery, unlike COPD or other conditions, restrictive lung disease that will last there for years. Okay, this one is short. So, some form of rehabilitation exercise that is prorated to the capability of the patient. Nowadays, it's hard to make them go to a rehab center to do that, but they can actually start walking around depending on their symptoms. They follow their barometers with, a bit of a challenge every day. Like they are asked to do a little bit more, but don't make them run immediately, because they might really have still something there that is the basis of long COVID. This condition actually improves in 3, 4, maybe 6 months. They're almost perfect now after 6 months. So not the type that we can label as chronic, not the type that really would require intensive rehab.
With regards, Doc, to adjunct treatments like vitamins, melatonin, bronchodilators, are they recommended to be continued during long COVID?
We don't have that information. We don't have that data. If of course they like vitamins, then fine, as long as they have a balanced diet and there are no contraindications with the other things. Like some may have sleeping problems, and they can have their melatonin if they have been used to melatonin.
Thank you po, Doc. A question from San Juan de Dios to Dr. Roa and Dr. Solante. Are patients with reinfections candidate for long COVID? And are there specific characteristics for patients having reinfections?
Okay, thank you for the questions now. So patients having reinfections are candidate. Well, I think if you look at if the risk for long COVID is also related with the severity of the infection. I think that's one information that we need to know. For those patients who had severe or critical and they survived, then higher risk also for long COVID, okay, because of the lung changes as mentioned by Dr. Roa. Now, if the reinfection can really occur and can they still develop severe and critical presentation? Yes, they can, because as I mentioned, there's no long-term immunity with the infection. And number 2, are there specific characteristic of patients having reinfections? I think the only important characteristic is that if there is re-exposure to a non-COVID patient, then that will give you a higher risk that a reinfection can occur.
Yes. So many of those who came from the ICU, they call it post-ICU syndrome, we call it. But in COVID, there are those also who recovered from home, milder case, and they still have some long COVID symptoms. So this makes it a little bit different. But as Dr. Solante mentioned, if they are re-exposed again with the virus and their antibodies have gone down, and there is some bad news there that antibodies don't linger so long, then they can always get reinfected. And I'm not sure if they will get long COVID even longer the next time around. I'm not sure.
Danny, I think we don't have questions anymore.
Yes, po, Doc. I think that that concludes all of our questions in the open forum. Thank you, po, doctors. Thank you, Dr. Solante and Dr. Roa, for your time. I think everyone has learned a lot about the updates and the new management that we can do for COVID